Okay, so kissing spines, the true term is overriding dorsal spinous processes. So basically this radiograph here, the dorsal spinous processes are kind of the finger-like projections. And at the top of those, you can kind of see where there's the dense white, very reactive looking bone. And so this is a case of very severe kissing spines. What ends up happening is the spaces between those dorsal spinous processes are become narrow. And then, especially when you put the weight of a rider, the weight of all the ingesta, intestines, it will actually kind of collapse them even further. They bang into each other, then they get a lot of this reactivity, and then oftentimes get a fair amount of back pain. So currently, this is the most common cause of back pain in the horse. So here's the axial skeleton kind of anatomy of the horse. It's actually kind of surprisingly similar to humans. The main difference is they have a lot more thoracic vertebrae than we do. We're honored to have a world-renowned human spinal surgeon in the audience, so I'm going to stay in my lane and hopefully not say anything to get shot down, but thank you very much for coming. Interesting speaking of earlier about this topic. Okay, so as far as the main areas that we're concerned about in the horse is the thoracolumbar spine. So basically the area of the chest and then kind of the abdominal area of the vertebrae. When looking at the anatomy here, you can kind of see the dark kind of pink areas in between each of those dorsal spinous processes, and those are what we call the interspinous ligament. So it's a small little band of tissue, but it's got a significant number of nerve endings in that region. And so those are the areas that get compressed, it gets tightened, they oftentimes get a neuritis, and then the bones themselves can also contact each other and cause significant pain. So that's the areas that we're kind of focusing on today. Most commonly, so the highest point on the withers is typically about the T5 vertebrae. So that's what the withers are. It's the dorsal spinous processes. They're much taller towards the front of the vertebrae. The areas that we have the most significant problems with is typically somewhere between T12 to about L1, L2 or so, with probably T14, 15 being the most common spot for kissing spines. So just like everything in medicine and everything else, there's grading scales. Most of them are things that you memorize and then forget later. So there's grading scales as far as what we're looking at for kissing spines. Grade 0 would just be a totally normal looking dorsal spinous processes. So that's there on the top left. So you can see the finger-like projections, and there's a pretty normal degree of space, and it's very symmetrical kind of throughout each one of those spaces. So that's what a normal looking back looks like. And then, I know the pictures are a little bit smaller, but then you get into the grade 1s. Basically what that just means that there's some narrowing of the space, not a whole lot of reactivity. The clinical relevance of these is definitely suspect, whether or not these are truly causing issues or not. And then as we go further down, you get all the way down to the grade 4, where they're actually very reactive bone. They're actually kind of overlapping. So instead of being kind of in an alignment like this, they actually kind of overlap, and there's actually no space in between them whatsoever. So those are kind of the grading scales. So this is a horse with kind of our fairly typical looking kind of back that has some kissing spines. Below it shows which vertebrae they are, so T12 through T17. And then basically kind of my subjective grading scale. Everything's a little bit subjective, but that's what I would kind of grade this back as. So not severe, but definitely there's some narrowing. You can see where it's kind of a denser white. That's what we call sclerosis, basically where those bones are contacting each other, and the body's natural response is kind of lay down more mineral, lay down more bone, and then they get that more kind of dense reactive appearance. When you see that, especially even if the spaces are wider, then you know that those areas are contacting. We think of the spine and the horse as being a really rigid structure, but all you got to do is have someone like me get on the horse, and that gets a pretty good bow to it. So as you weight the horse with the saddle, with the rider, that spine will definitely get a little bit of a flexion to it, and then those kissing spine areas come in more contact. As far as clinical signs go, it's kind of all over the place. Most of the time, it's usually a performance issue. So these horses, especially if it's a horse you've had a while, all of a sudden, depending on whatever discipline it is, start having issues with behavior, with if it's a barrel horse, they have an issue going to the first barrel. All of a sudden, they're going down the arena, missing that first barrel. Maybe they're getting really agitated outside of the arena as they're going in. Same thing with kind of the dressage horses, the jumpers. It's just mostly it's behavior issues, reluctance, refusal to jump, irritability when saddling. So horses that are really nice, easy going, sometimes as you're cinching them up or tightening the girth, they get irritable. They may reach back and kind of bite at you. Just these things that are kind of abnormal. And then there's obviously bucking, having issues kind of swapping leads inappropriately, decreased kind of hind limb propulsion. So all kinds of different kind of clinical signs that go along with this. I didn't even know that Dr. Rick put a Charlie Russell picture in there. So this is my version showing that even in the late 1800s, there was kissing spines in horses. So it's been around as long as the horse. It's just more recently that we've been looking for it, and now the client base knows about it, and so people are even more focused on it. So I think probably the most important takeaway from my talk today is not all horses with radiographic signs of kissing spines have clinical problems. So this is a horse that's definitely got some narrowing, got some reactivity, totally normal. This horse had never had any issues with back pain, never had any performance issues. We were snapping some radiographs of its back because the owner wanted to check, and we found this. So that's one thing. You ride the horse, you don't ride the radiographs. And you can start searching for things and you'll find them, but whether they're clinically relevant, that's what you have to try to decipher. So this is a video of a dressage horse. As you can kind of see, as makes the turn, you kind of see the tail swishing, acting a little bit irritable, a little bit grumpy. And then as we get kind of further down the arena, that's when things kind of start to come apart. And so this is a horse that was diagnosed and confirmed to have significant kissing spines. And so these are just some things that we kind of, hopefully not this severe, but things that we kind of look for. When we're examining the horse, these are kind of things that we're listening for and seeing, okay, does it sound like a horse with back pain? Does it sound like a horse that has some other type of orthopedic discomfort? Switching disciplines, so barrel horse. Little bit probably choppy going into the first barrel. This is a horse that had competed really high and then just says, nope, not happening today. So there's obviously other things. There could be training things. There could be other orthopedic pain. But just when you start hearing some of these complaints, especially on someone that's had a horse and that's performed really, really well and then all of a sudden starts tapering off, then you start going, okay, I wonder if something's going on in the back. So in medicine, just like was spoken earlier, getting an accurate diagnosis is the most important thing. Otherwise, we're just throwing darts and hoping that something sticks. So with kissing spines, we need to rule out a lot of other things, and this is just a handful of probably the 100 or so different things that we're kind of making sure that they don't have. Gastric ulceration, everyone's very familiar with that. Causes similar symptoms. They can get osteoarthritis or spondylosis. So this particular radiograph, it's probably a little bit hard to see, but so the kissing spines are up top. It has some mild changes, but if you look down lower, where the actual kind of vertebral discs are, there's what we call spondylosis. So there's bridging. There's definitely some significant abnormality in that horse's back. And so sometimes these things kind of go hidden. Kissing spine's like the tip of the iceberg, and we got to figure out is there other stuff going on down below the water surface. Orthopedic pain, so obviously any type of a lameness issue, they can have sore sacroiliac joints, they can have sore hocks, they can have all these different things that will sometimes cause some of these issues with performance. They can have TMJ pain in their jaw. They can have abnormalities with just their dental, with the way that their teeth are. Can be hormonal or reproductive. I think I'm outnumbered in the male to female ratio. I'll just stay away from that. Obviously training. So some of these things are literally between the ears, and that's probably the hardest thing that we have to deal with as veterinarians is I don't have a big couch for them to sit down and tell me why they decided to bolt off. So there's other issues that are going on that are not actually related to any clinical abnormality. So many more things. This is just a horse that's got pretty significant gastric ulceration, and so that's something that we kind of want to try to rule out. So with everything in veterinary medicine, it all starts with the clinical exam. Obviously, history really helps, but really getting your hands on the horse, using probably our hands as far as the sensitivity of our fingers and trying to figure out where kind of pain and different things are coming from is the most important part of the clinical exam. Oftentimes, horses that have back pain will have concurrent hind limb pain, so they may have hock pain, they may have some chronic proximal suspensories. There's not as much literature kind of proving things yet, but definitely having a negative plantar angle of the coffin bone and the hind feet, so having really low heels, kind of get like a bullnose appearance to the foot, kind of rocks everything back. That seems to kind of go hand in hand with horses that have either hock pain or sometimes lower back pain. So there's a lot more things to focus on than just the back itself. Like to watch them on different surfaces, like to watch them how they go at the walk, at the trot, watching them circle, seeing how they transition from trot to canter or lope. So just a lot of different things to try to decipher between. I always forget how small I make horses look. This is a pretty, this is actually my favorite horse, but he's a pretty good sized quarter horse. And I saw that picture and I was like, man, that's kind of embarrassing. So we want to palpate over the back, checking for signs of heat, inflammation, signs of focal pain, checking the muscle tone. So the apaxial muscles, they're the muscles that kind of go on either side of your spinal column. They're your core. I didn't know what my core was until my wife got me in a Pilates class, and then I realized how important that is. And so checking for muscle spasm, kind of the fascia overlying, trying to palpate the dorsal spinous process themselves, doing range of motion of the neck and the back, just looking for all these different symptoms that may lead us to showing that there's abnormalities there in the back. So diagnostic imaging is where we kind of go to next. Radiographs are spoken of. They're obviously been around forever. Very easy to do here at the clinic, out in the field, and it's a very easy way to make a diagnosis of having abnormalities in the dorsal spinous processes. This is these pictures are actually of what we call a nuclear scintigraphy or a bone scan. And so it's probably a little bit hard to make out. The lines, kind of symmetrical lines going down, those are the ribs. The darker area in the middle is the main kind of vertebral bodies, and then those kind of dark dots at the top is where there's some kissing spines. So there's a lot of reactivity in the bone, and so this helps us when we confirm it with radiographs, and then we see this on bone scan. It shows us that there's definitely a lot of inflammation taking place there. The big kind of circle-looking thing is the kidney. That's normal. So that's other things. Ultrasound. So we want to also check and see, does this horse have arthritis in what we call the facets or the joints of the thoracolumbar spine? Is there abnormalities in the musculature? So sometimes these horses with chronic back pain, they start to get atrophy and abnormal kind of muscle deposition. So these are all different things that we'll do with diagnostic imaging. So once again, this is a horse with kind of, I'd say, moderate to severe kissing spines. Let's see, I think next slide. This is an overlap. So this horse had a bone scan. It was the one that I just showed you. And so I can kind of overlap that on the radiograph that was obtained. And then basically where those areas of yellow are, it means there's increased uptake. The area where the vertebral bodies, that's pretty normal. That's a normal uptake pattern. But the two little kind of pinpoint areas, that's very abnormal. So that lets us really know that this horse does have some significant inflammation going on there. Another things that we'll do, and this is very much dependent on the patient and the client, is sometimes we'll actually block their back. So just like nerve blocks, you guys are probably familiar with, if your horse is lame, we put a little lidocaine or carbocaine around the nerves of the foot to see where lameness comes from. We can do similar areas where we kind of use radiograph guidance, stick the needles in around those areas where there are kissing spines. This one I'm doing for surgery, so it's a little bit different, but if the horses are amenable to being ridden and they're not too dangerous, you can block them and then recheck them in 30, 45 minutes or so and see if there's a significant difference. Some of them don't block out, especially if it's really chronic, but if the behaviors are totally the same after a block and the radiographs aren't that bad, I'm a little bit more reluctant to pursue surgery. I'm looking for other things that may be causing the abnormalities. So this just shows placing some needles there, depositing the local anesthetic in those areas. Okay. And then this is just from one of the scientific papers, just kind of showing the distribution. So the pale gray are horses that were treated surgically. The dark gray are ones that were treated medically. The main reason I put it in there is just showing the vast majority of the kissing spines are usually from like T14 to about T18 or so, somewhere around there. So that's a real common spot. Happens to be right where your saddle sits. So you're sitting right on top of that region. So. Okay, so treatments. So like I mentioned, I'm a surgeon. I like to do surgery, but not everything needs surgery. And I really want to determine, is this horse truly suffering from kissing spines that are causing clinical problems? Or is this horse happen to have some radiographs that look bad and it's got other things going on, and I don't want to be treating one thing and then have people come back 6 months later and say, yeah, the thing you did didn't work, and something else was going on. So, so a lot of times we'll start with kind of more conservative or medical management, depending on the severity of things. Obviously rest, that's the ancient kind of treatment, the most benign. So doing physiotherapy, so I think it is important for these horses, like I mentioned, the Pilates thing, stabilizing their core is an important component of this. Doing different stretching, different exercises to try to build that up is definitely an important part of this, this treatment process. Systemic anti-inflammatories, so your typical non-steroidals, bute, banamine, equiox, whatever you pick. Methocarbamol is sometimes beneficial. It's thought to be kind of more of like a muscle relaxant. It can kind of make them a little bit sleepy, a little bit too, in higher doses. So these are some of just the oral medications that we'll use on them. We do intralesional injections, so probably most commonly putting longer-term anti-inflammatories in there, so like corticosteroids. We have done, especially on horses that maybe have like tearing of the ligament, not as much of the spaces kind of banging together. You could do regenerative products, so platelet-rich plasma or stem cells, whatever your favorite concoction is. The other thing that we'll do for these is shockwave therapy. So this has been beneficial in horses with sore backs. It seems to help improve comfort, and so these are kind of the more conservative things. I typically like to see either how the horses respond to the blocking at the time of the exam, or I like to see how they respond to some of these medical therapies before we just dive into doing surgery. So that's kind of where we start typically. There's multiple different surgeries that we do, so I'm just going to kind of highlight the two most common ones. So this is a technique that was reported about 2010 or so, and it's basically what we call interligament desmotomy, interspinous ligament desmotomy. This is done under standing sedation, so like if you've had your horse's teeth done or any procedure like that, we just sedate them. We do the local anesthetic, so they're not really feeling anything there, and then we use radiographic guidance to place these needles in there. We do kind of through minimally invasive, so just little stab incisions, and we're able to use little instruments to go in. Basically what we're doing is cutting those ligaments, trying to open the space up a little bit. Most likely what we're doing is actually kind of doing a little neurectomy and doing that, so we're cutting through some of those nerve endings. This has been a very successful procedure on horses that have significant discomfort, and it has performance limiting issues, and so depending on what paper you read, anywhere from 70 to about 95% success rate. So the success rates are quite high. The main thing I want to also point out is a lot of times these horses have concurrent lameness issues. So a lot of times you got to treat both or multiple areas. It's done minimally invasive, and so that's a nice thing. Usually within about 6 weeks, maybe 8, these horses are back to exercise under saddle and kind of hopefully going on with their day. So that's the first technique that we'll talk about. It does open the spaces up a little bit, but it doesn't give you a huge gap in between. So this is a horse. The ones on the left are the pre-ops, not severe, but definitely has some kissing spines. And then the one on the right, same vertebral kind of bodies, and you can kind of see there's a little bit of a widening of the space. Like I mentioned, the biggest thing is releasing that tension of that ligament that's damaged, and then also basically probably desensitizing it from the neurectomy component of it. So that's that procedure. And then the next one, this can be done a multitude of different ways. This can be done under general anesthetic, so the horses are on the surgery table. There's also techniques where we're doing this under standing sedation. And so this is where we're actually going in, we're removing a segment of the bone. And so this is called an ostectomy. I typically do these under general anesthetic. When you take a horse that's standing, has all the weight of the abdominal components and everything on it, and then all of a sudden you lay that horse on their side, those spaces actually open up. And so I find it easier to be able to get in there and kind of remove the bone that we want. You can kind of see on the picture below, the spaces are quite a bit larger. You're doing a very similar procedure in the sense that we're removing some of that ligament and then also probably causing a little bit of a neurectomy as well. So similar success rates. Return to use, this is a little bit longer because you're usually going through a larger incision, but somewhere about 8 to 12 weeks or so. And it just is very case dependent on which procedure we do. If the horse has really significant overriding kissing spines, we're typically doing something more along these lines because honestly, when they're really overriding, there's no real space for us to get in there to be able to remove that ligament. So, so those are the kind of the two main surgeries that we do. There's other ones, but those would be the most common. And then as far as the follow-up, just like anything, surgery is only as good as the rehabilitation. So we do like to put these horses into a rehab plan. You're typically looking at maybe 3 weeks of stall rest with hand walking. After that, then they can go out into a small paddock, continue the hand walking. We want to do stretches. All you got to do is go online. You can find all kinds of different ways, but doing stretching and mobility is really important daily. And then as far as going back, just you kind of have to, it's case by case, but you want to make sure and find out a good way to appropriately warm the horse up before asking them to do whatever it is athletic you're asking them. Checking saddle fit, so that's a very important component. And then also rider balance. There's some really good riders and there's some not so good riders. I fall into the latter category. And so those things can definitely affect the horse's back. And then, so Dr. Teskey, she's one of our resident veterinarians. She does a lot of acupuncture. I don't know what acupuncture does. I have no clue. I wasn't trained in it, but I do think that it is beneficial. And so I always kind of preface that. I've seen a lot of these horses show quite a bit of relief as far as the spasm and everything in there, and I don't know what it's doing. Never had it done myself, but I just put that out there. And then also shockwave that can be also performed as follow-up. So anyway, so at this time, hopefully gave you a little bit of information. Like I said, there's tons of Facebook posts and all kinds of stuff about kissing spines now, which wasn't really the case probably about 10 or 15 years ago, but I'll turn it over to any questions. So, go ahead. Yeah, so as far as the cause is probably genetics, conformation. There can be things that exacerbate it. So if they have some type of an orthopedic pain, then they're going to be carrying themselves differently. Their back's going to get tighter. Their musculature is going to spasm a little bit. But a lot of these horses, like we can take radiographs of a yearling or a 2-year-old, and they'll have these changes sometimes. The other interesting thing is racehorses definitely will have kissing spines, and it can be problematic. But for the most part, a lot of times those horses do okay with them. They're running totally different. They're completely extended. They're not collected at all, and they're not putting a ton of compression on their backs. And then that horse, as a 4 or 5-year-old, retires and then becomes an eventer, and all of a sudden those kissing spines become problematic. So that's another interesting thing that we see is, depending on whatever discipline they're doing, the way that they're collected, that also probably plays a role whether they're clinically relevant or not. So here we go. All right, Dr. Johnson.
Fascinating talk, which I didn't know anything about kissing spines in horses. I know a lot about people, and kissing spines are pretty rare. I want to ask you a question from the diagnostic standpoint. When you work up your patient, is it clinical exam, injection? I mean, what's your sequence of things that you do when you're evaluating them?
Sure. So if I'm the primary provider and the horse hasn't been seen anywhere, it's coming into me for just some type of a subtle performance issue, and I kind of pinpoint showing some back pain, and then I see, okay, there's some radiographic changes, and it seems it all fits. I usually go for more like injections because I want to see how they work, and I want to make sure that in treating them, hopefully there'll be a response. And then with those, they don't last forever. It doesn't really fix the problem per se, but you can hopefully get 12 weeks or more, or sometimes even longer, especially if you start implementing these other aspects. And so that's typically where I start. If the horse has been seen multiple times, or if it's really severe and it's a no-brainer, then I'll jump towards surgery and stuff. But I like to see how they respond, either with local anesthetic during the exam or with treatment, and then kind of follow up.
So I guess now you open it up, and I said, you give them a local anesthetic, and do you give them a steroid also? So that's a diagnostic and a therapeutic one. So walk me through that.
Sure.
So I understand.
Yeah. So as far as the anesthetic would just be more for the clinical exam. So I would do that. Let the horse sit for maybe 30 to 45 minutes or so. If it's an under saddle exam, some of these are horses that act up like on a lunge line or in a round pen, and so you can kind of see a behavior change without being saddled. If it is more of something that's under saddled, then I'll kind of let the block set, have the rider get back on about an hour or so later, and recheck to see if there's significant improvement in the clinical signs. And if that's the case, then talking with the owner, deciding what's probably the best route, then I would do a follow-up later treatment with the corticosteroid or so. Yeah.
Fascinating talk. Thank you very much. I'm the student here, so thanks again.
Thank you. Thank you for being here. When you look at our patients, as well as all the kind of publications and stuff, success rates are quite high. As far as returning to peak performance, it's probably closer to maybe 75%, 80%, where some of them, have significant improvement. That's a hard thing especially in our studies. A lot of it's retrospective, and it's kind of follow up, and a successful outcome is just that the owner is happy with how things went and stuff like that. So, but as far as getting horses back to complete peak performance, sometimes it's a little bit less. Yeah.